So welcome to the first session of our course. We're excited that you've chosen to join us every Saturday and some Sundays for the next several months. We are really hoping that you will find value in what we have to present today. Just to give you a bit of background, we are physicists from all over the world, or all over the US, sorry. And we are really passionate about promoting high quality care for our patients, and we hope to share that with you today. Today, we'll be kicking off the course with a discussion on the role that a physicist plays in assessing and promoting treatment plan quality in the clinic. And I noted that there are a lot of different professions on the call today, and this really is not only for physicists. This skill of evaluating treatment plan quality is really applicable to everyone on this call. So today's session will include a background on the importance of plan quality, a discussion of what we're hoping to accomplish over the next several weeks, tips and tricks for promoting a culture of plan quality, an explanation of how the course will be structured, and a few final thoughts to leave you with. So first, let's talk about the importance of plan quality. But first, we really need to define what is quality. And if we look in the dictionary, quality can be defined as how good or bad something is. When we consider objective quality, it's often black and white. So if you look at the left-hand side of the screen here, the bananas, taking for example, objective quality of the banana on the right is no longer good. It's really past its prime. But you can also consider subjective quality, that kind of subjective nature, where, for example, you have these two apples, and one may be better than the other, but it really may depend on preference. It may depend on what the apple is being used for. The red one might be slightly sweeter, but you really wouldn't know that until you have inspected it further. So treatment plan quality can be defined as the degree to which a dose distribution maximizes tumor control probability and minimizes normal tissue complication probability for a given patient. And really implicit in this definition are three pillars. So you have the notion that the plan is safe. It will not cause harm for a patient. Also, that it accounts for uncertainties that affect the accuracy of the dose calculation and delivery. So that's the robustness of the treatment plan. And can the treatment plan be delivered within a reasonable amount of time and resources, which would be the definition of something being efficient. So these are really the three pillars of plan quality that we hope to instill over the next few weeks. When we're assessing treatment plan quality in an objective manner, we're going to consider three categories. And each plan we're assessing might fit solidly into one of these three buckets. So the first is if a plan is unsafe for treatment, as we were saying, this plan would be considered unacceptable. Some examples might be if the plan were to collide with the patient, that would cause the patient physical harm in that way. Or if the plan actually is going to give too much dose to a spinal cord, also would cause physical harm to the patient. So these would be examples of unacceptable or unsafe plans. The next type of plan we'll consider will be acceptable plans. These plans will not cause harm, but they still could be improved. So some examples here might be a plan where you could spare the carotids more for a head and neck patient, the prostate or bladder the rectum or bladder for a prostate patient. And so these plans don't cause harm, but we still can improve them. And then finally, we have high quality plans, which is what we're hoping we're going to be teaching you how to assess and transition acceptable plans to high quality plans. And these plans strike a balance between target coverage, normal tissue sparing, robustness, and efficiency. And this will give you, so that's how, where we're looking at looking at treatment plans objectively and seeing that they're going to fall into three distinct buckets. But in reality, there's that subjective nature to plan quality review. And most of the plans in your clinic are going to be on a spectrum, falling in this acceptable plan quality area. And the majority of plans that you'll be reviewing are acceptable, but could be improved. And that's really where the physicist comes in. And the goal as a physicist is to ensure that the plan created is as high quality as possible. So we're looking to take acceptable plans that might be created and transition them to be as high quality as possible. And that's what we're hoping that you're going to gain in as far as skills throughout this course. So there was a really nice study that was done, and this study was completed back in 2010 in the US, and it was spearheaded by a physicist named Ben Nelms. And what he did was he took a single data set, a contoured data set, and he sent it around to many participating institutions. And that contour data set also came with scoring rubrics so that the people who were creating the plans knew ahead of time how the plans would be scored and assessed for quality. And every planner was asked to create the best quality plan they possibly could, keeping in mind this scoring rubric. And so what was shown by this study was that the ability of the treatment planners to meet the objectives that were given ahead of time with that scoring rubric was not dependent on the statistical or not dependent on the demographics. So their years of experience, their confidence, their education, and it also was not dependent on the technical parameters. So what treatment planning system they used, how complex the plans were. But what it did show that there was a huge variation in plan quality. And what can be taken away from this is that planner skill is very important in the quality of the plan that's created. So that points to the need to be able to understand how to both achieve high quality plans and to assess treatment plans for quality so that you can identify when plans can be improved in your clinic. So on the screen, you can see an example from my own clinic. And this is a prostate and nodes plan. This plan was completed by an experienced planner. The planner has over 20 years of experience as a dosimetrist, and it was approved by the physician for treatment, approved by a physicist for treatment, and then treated. And it's by all means an acceptable plan. However, after we, there we go. After we implemented standardized planning procedures and techniques that are taught by RCC, which will be highlighted in the session tomorrow by my colleagues, you can see here that the sparing of the bladder, the rectum, and the bowel was significantly improved. So I'm going to flip back to the other slide. So the isodose line that you see on this screen is the 50% isodose line. You can see it's pretty much washing over the bowel, spilling into the bladder quite a bit, and then quite a good distance from the edge of the PTV into the rectum. And after creating those rules-based, standardized planning procedures and techniques, you can see really an increase in sparing of OARs in this case for this patient. What's really important is that truly both plans were safe and acceptable for treatment. We use these scripts in our clinic to assess dose to the OARs and whether or not the DVH parameters are acceptable and safe for the patient. And both the first plan that I showed you and the second plan that I showed you would have passed and met all of the objectives outlined by the physician ahead of the patient being planned. But if you assess the isodose lines, which I already showed you, and the DVHs, you can see a visual of the DVH here. showing drastic improvements in the bladder DVH, which is in yellow, the rectum DVH, which is in brown, and the bowel DVH, which is in purple. So huge improvements, likely meaningful for this patient as far as some toxicity. And so the take home here is that these plans are really in each and every one of our clinics. And there are so many that would benefit from significant improvement in plan quality by using a systematic approach to both planning and review of the plan. So if you're able to identify when you review a plan that the plan can be better, this would allow you to help your teammates create improved plans. So Task Group 38, which is a task group published really many years ago by the AAPM in the United States, defines the first responsibility of the radiation oncology physicist to be to the patient, to assure the best possible treatment given the state of technology and the skills of the other members of the radiation oncology department. So I really take this to heart. This is really how I like to practice as a physicist. How can I do my part in assuring the best possible treatment for every patient who enters our clinic? And as a result of our training, physicists have a unique expertise and understanding of imaging, optimization, dose calculation, and robustness. And don't worry if you don't feel that you might possess all of the skills now to assess the quality of treatment plans, because the goal of this course is for us to provide you the tools that you need to build the understanding and intuition that will help you in reviewing these treatment plans to ensure high quality. So all of these skills that a physicist possesses, and also within the context of additional skills of the multidisciplinary team, because you'll hear us talking a lot today about the importance of the team-based approach to assuring high quality in the clinic, can really go a long way in creating the best possible treatments for our patients. So I will pause here to launch our first Zoom poll. And the Zoom polls that we have created for today, like Emily said, are mostly just to get a feel for where everyone is at the beginning of the course, so we can help tailor the rest of the course. So our first question here is, in my clinic, I assess if a plan strikes a balance between target coverage, normal tissue sparing, robustness, and efficiency, always, sometimes when I have time, never, and I didn't realize this was part of my job description. So we'll just give some time for the questions or answers to come in. And then I think, like we were saying, you can put your answers in the chat too if the poll is not working for you. So
all right, we have about 70% answered. So I'll go ahead and end the poll, Lindsay, and share the results so everyone can see them.
All right, well, this is exciting. It looks like the majority of people are already assessing these things in their practice. And this is, something that I have just learned over time. And I think we're all trying to do our very best given time constraints. And we'll have a lot more to come in the next few slides.
Lindsay, we have a couple questions from the chat.
Okay.
So in the example that you showed with the prostate nodes plan, one question is how long did it take to optimize the first plan? And I'm also curious, what was that difference in planning time between the two techniques?
Sure. That's a really good question. And so tomorrow we will be giving a refresher, because this Schulman method of VMAT optimization, which is the method we were using to optimize the second plan, is the method that RCC teaches for planning. And the neat thing about it is that it probably took less time to optimize the second plan than it did to optimize the first plan. just because of the way the optimization strategy works. So it is all about really setting up the optimizer and contours up front to give you the best possible chance of getting a really good plan with one optimization. So likely the first plan may have taken the dosimetrist a few rounds through the optimizer to get that first plan where there was 50% spill, but the optimization objectives that were used were not ideal for that patient. So it's really all about trying to understand the physics of dose fall off and get an intuition for that, and being able to put optimization objectives into the optimizer that will be ideal for a given patient.
Great. Yeah, I'm looking forward to hearing more about that technique tomorrow. It sounds pretty amazing. A couple other questions kind of tied around, I think, like artificial intelligence or plan scripting. Does that have a role here, specifically for this example, but also generally for this class?
So specifically for this example, no AI role. These were two manual plans. The only scripting that was done was the script that I showed you to just assess the DVH parameters at the end of the planning. But these were two manual plans. There is, like, AI can play a really good supporting role when it comes to reviewing plan quality and also creating high quality plans. And we will have one session in this course focused on that.
Oh, that's fantastic. Yeah, because I think that that's a great question. And then finally, another question about specifically about those two plans. I think the big point really is that if you look at that, the DVH numbers, they were both perfectly acceptable, right? So they meet constraints. But one attendee is wondering, how do you actually find out if that plan needed better quality? And I'm thinking that's actually, we're going to delve into detail on a disease site specific basis moving forward throughout this course. Is that correct?
That is correct. So that's kind of the whole background for this course. What we're hoping to give intuition on is when you're reviewing a plan from the start all the way, like the intent of the physician, and this will actually be in the next couple of slides, all the way through the planning process until the plan meets the patient. During each step, what are you doing to analyze if a plan can be improved? Specifically for the example that I showed, you could use I think the most important intuition to gain is in dose fall off. And your review of your isodose lines are going to allow you to understand if the dose distribution can be improved, because there are really standard expected dose gradients, and it's all relative to the prescription dose, and at different distances, how much you expect the dose to fall off. And that is like one really powerful tool that I use when I'm assessing plan quality. When it comes to the sparing of OARs, there's a lot more that we'll discuss throughout the presentation that also is important for quality of the plan.
Awesome. Thank you. Thank you, Lindsey.
Okay. All right, so we will move on. And so next we're going to talk about the course goals. So these are in line with a lot of the questions that we just got. So I'm excited about that. So we have three main goals for this course. And the first goal is to provide practical guidance on how to effectively review the quality of a clinical treatment plan. So currently there exists some very good guidance. It's really excellent from Task Group 275 on how to check the technical parameters of a treatment plan. So checking that the MUs are correct, that the parameters transfer from the treatment planning system to the record and verify system. But when it comes to plan quality, it's a pretty short section of the report. And so our goal here was to expand on this guidance to provide education on things you should be looking for when reviewing the subjective quality of a treatment plan. So the first few sessions of the course will be giving more the backbone, like the general guidelines on how to review 3D, IMRT, SBRT, and SRS plans. And then the bulk of the sessions will be more site-specific, providing guidance on different anatomical treatment sites treated in radiation oncology. And then we'll conclude with some information on AI, like I was talking about. So within that goal number one, we are going to provide practical guidance on how to effectively review the treatment plan. And this will include following the patient throughout the entire process, from the patient assessment and intent to the simulation phase, which will provide information on how to review the setup of the patient, image quality, the motion management, and then spend a lot of time talking about that treatment planning phase, which is where you can do a lot for improving quality for patient care. And then finally, we'll talk about communication. So communication between the entire team and how to use different deviations that might occur during the planning process to improve the process for future patients. And then the second goal of the course is to provide many practical examples, like the first one that I showed today. That's just one example you'll see in this course, but our course is designed to provide many, many examples. And we're hoping that the examples will illustrate the concepts being taught. And with the use of these site-specific examples, we're hoping that you can gain greater mastery and intuition of these concepts, so you can apply them to your own clinical practice when you have something. One of the main things that shows that you've learned something is when you can apply what you've learned in a new situation. And so we're hoping that having all of these examples will not only allow you to see the theory behind what we're teaching, but also be able to translate it into clinical practice more readily and be able to apply these concepts in your own clinic. And then the final goal of the course is to improve both your competence and your confidence. So both of these are very important. If you look at the illustration on the right, you can see the strong correlation between competence and confidence. And in the clinic, we often find people at different stages in this illustration. So as far as I'm concerned, it's completely okay to be in this newbie meadow down here. You're fully aware that you have a lot of knowledge to gain before you can improve your competence with a particular clinical concept. And this I'm just applying throughout, this is how I think about things in my own practice. So not only for plan quality, but for really anything that I'm learning, and just a nice concept in education. So it's okay if you're in this newbie meadow, you're learning, you're open to learning, and you're going to just continue your journey in education on the topic. The most dangerous situation, I think, is when you stand here on top of Mount Arrogance. This is where you might have a lot of confidence in your decision-making, but maybe not enough knowledge or competence to make the correct decisions. This is usually where mistakes happen. I'm not saying mistakes don't happen. They happen to everyone, but a lot of mistakes do happen when we sit on Mount Arrogance. And then there's this valley of despair. This is the point along the curve where you might be gaining knowledge you need to make the correct decisions, but you still need consistent exposure to different examples to build your confidence and to make appropriate decisions for your clinic. And this is where we're hoping that this course will lead you on the path of enlightenment to the plateau of sustained confidence. So that will lead us to our second Zoom poll question. And this is going to be, at the beginning of this course, do you feel that you're in the newbie meadow when it comes to reviewing plan quality, sitting on top of Mount Arrogance, in the valley of despair, or on the plateau of sustained confidence? Having a pretty good split here. It's less on Mount
Yeah.
Arrogance, so that's a good thing. So we're really hoping that this course will help you gain confidence and competence. And we have a lot of educators who have put a lot of time into putting together really good content that I think will be very exciting for everyone. Just feel really honored.
All right, the response rate is slowing down, so I'll go ahead and into the poll and share the results. And yeah, like you said, Lindsay, it is a very, very good split between all the answers, actually.
Yeah, I think so. And so we hope to be able to help everybody who's feeling in that newbie meadow. We have a lot of examples to show throughout the course and a lot of content that I think will really help. And those of you in the Valley of Despair, where it just feels a little bit overwhelming, how to really get your hands around creating these high quality plans, we're really hoping that we can provide content that will help with that, right? So any questions on that section? Great. All right, so then I am going to stop the, oh wait, did we share the poll results here?
Yeah, I did. So I think
Okay.
we're okay. Yeah.
So with that, I will hand it over to Leah. Leah is a colleague of mine who's very passionate about education, and she has a lot to share with you on promoting a culture for plan quality.
All right. Thanks, Lindsay. That was great. Let me go ahead and share my screen. Let's see. All right. Can everyone see just the slides of my screen?
Yes.
Yeah? Okay. All right. Sorry, I'm just two monitors, gotta get everything set up. Okay, so just the slides. All right. Okay, great. All right. Well, thank you everyone for being here. I'm very honored and excited to be here. So we're going to shift gears a little bit and talk about how do we create a culture of plan quality. I like to think of it as how do we actually make this happen in our clinic in real life, right? So, okay. And what is our role in that effort? So physicists have an important role in establishing a culture for plan quality. The first step is simple. What we can do is simply start to look for it, right? This course will help us do that. When you're planning or reviewing plans as a physicist or a physician or a planner, start by looking for plan quality with a critical eye. Ask yourself, is this the best dose distribution for this patient that's feasible? Could we change any planning parameters to improve plan quality, robustness, or efficiency? Could we change the planning strategy for either this patient or future patients? So moving the needle from an acceptable plan to a high quality plan can start with us. But once we start looking for plan quality, however, what do we do next, right? How do we actually move the needle in real life? And this is where culture and soft skills come in. So we know that creating high quality plans can take extra time and effort, especially at first. Although with that example that Lindsay showed, I think the opposite hopefully is true, using some great new tools that this course will hopefully introduce. But, there's always going to be a barrier at first, a barrier to change, right? So extra time and effort could be either when a planner is creating that plan up front or afterwards during a plan review if you have to ask the planner to replan. Also, because of the subjective nature of plan quality, it's not always an easy decision, right, to move from the acceptable plan to the high quality plan. The planner might need to do more work. The physician might need to as well. The patient might need to be rescheduled. So just like there's a spectrum of plan quality, there's also a spectrum of costs associated with plan quality. So even if a physics plan review identifies an unacceptable plan where the decision to replan is very straightforward, there's always going to be some type of cost if you have to replan, right? And ultimately that's going to have an impact on people. So because of that impact on people, physicists need people skills. So there's a way to establish a high quality planning program effectively and constructively. by our own individual actions, interactions, and by establishing a culture for the entire workplace to prioritize plan quality. So that's why we're introducing this concept and really digging into culture in order to hopefully make it more successful, that the concepts you've learned in this course can actually be implemented in your own clinic. So, how do we actually go about doing that? We do need to change that culture. And what do I mean by culture? So, culture is a set of shared attitudes, values, goals, and practices that characterizes an institution or an organization. So, let's break that down into some specific elements. We can turn to the concept of safety culture, in which the IAEA has defined as the set of characteristics and attitudes that assures that, as an overriding priority, safety issues receive the attention warranted. Now, the IAEA has defined 10 elements or traits of safety culture shown here on these slides. If we use this as our analog for plan quality culture, we can start to look at those traits and talk about some practical tips. So we'll actually focus on a subset of these culture traits today, although all of these can apply to a culture of plan quality. We'll focus on environment, communication, and continuous learning and education, their role in promoting plan quality, and tips on how to establish these traits in your clinic. And I'll just pause here for if there are any questions from the audience.
There was a question. Someone said I think that maybe the transcripts stopped. Are people still seeing their transcripts? If anyone is not, just let us know. Okay, all right, seems okay. Then I think you're good.
Okay.
Leah, keep going.
All right, well, let's dive in and talk more about these kind of three traits of culture. So the first trait has to do with setting the right environment. So the environment when working on treatment plans should be collaborative. I'm sure many of us have been in this environment before, right? We want everyone to be on the same page so that we can work collaboratively towards a shared goal. So we can start by doing that by setting expectations early, by openly discussing the goals of establishing a high quality planning program, emphasizing the shared values that we're working together ultimately for the patient, right? Everyone gets on board with that, right? That's why we're all here, why we're working in this field. So if everyone knows these goals, then it's not a surprise when asking for those additional efforts for change or for planning and reviewing plans in order to reach the goal, moving from adequate plans to high quality plans. So I'll give a recent example. So in my department, when we train our physics residents on physics plan reviews, one of their assignments is to ask the planners, how do they prefer to be approached if the physicist finds an issue and asks for an improvement to their plan? And one planner said, I expect the physicist to catch things, so please catch them, but also let me know about it so I can improve for the future. If we all have those expectations in common, then collaborating to achieve a high quality plan becomes possible. Another key aspect in a collaborative environment is respectful interactions. If you find that a plan's quality needs to be improved, approach the planner in a non-punitive way and focus on finding the solution in order to improve the plan. Try to take a team approach where all team members, from front desk to physician, provide different perspectives and valuable information. There was a comment earlier in the chat talking about how it's important to understand kind of the backstory about the patient and understand the physician's thinking and how we manage that particular case. And that makes a big difference in the plan that gets generated. And so I think that's a great example of showing how everyone's input really can make a difference in plan quality. Another example I'd like to share in my clinic, where kind of more on the technical side, the dosimetrist and I were just discussing how best to document an alert that we wanted the therapist to know about for a particular plan during treatment. Instead of just making a decision with just the two of us, we just asked the therapist, what about their workflows? How best would they be alerted so that we knew where best to document where they would see it. So in the end, it was a very simple thing to do, and it ultimately gave us the best solution by collaborating and valuing everyone's input. Finally, through these approaches and actions, trust is gained. When there's trust, it becomes easier to make the extra efforts towards the common goal of high plan quality. The next element of plan quality culture is communication. First of all, in order to get everyone on board with the same goals of high plan quality, you have to communicate that, right? So ensure that those goals are clear and easily accessible to all. Planning standards, expectations, workflows, techniques should be communicated to all staff, and especially when new staff are hired. Some ideas for doing that can be to create a central repository of procedures, guidelines, and tools, or a wiki or central internal website, so that planning and plan review resources can easily be communicated and accessed. Then it comes to the individual manner in which we communicate, right? Especially when we're giving feedback on plan quality, when we're evaluating plans. So if you think about it, we're either catching errors or suggesting improvements on someone else's work. If you've ever been on the receiving end of that, it can be hard to take and can easily be taken as negative criticism, right? We all want to do a great job, and it's hard when someone comes back like, oh, you didn't do as good as you thought you did, right? So we want to take a constructive approach. So come from a place of seeking understanding instead of leading with, you made this mistake, or how could you do this? Try, can you help me understand why this looks this way? Is there a backstory or a reason for the dose distribution to do this or that? Focus on the plan or the planning process and ways to improve, as opposed to putting blame solely on the individual planner. And tone is important. Very subtle, but it can make a huge difference. This in general is just respectful or constructive communication, approaching people in a respectful way, appreciating their abilities and judgments, and that it's unlikely that they produced a poor quality plan on purpose. Next, communication should be regular and timely. This makes sense when we want to improve plan quality. The timeliness is based on the clinical timeline. We need to treat our patients. So we do need to address things very quickly. However, when clinics become very busy, and especially when different staff cover different clinics or remote work is a factor, regular and timely communication can be hard to achieve in practice. One idea is to establish a communication plan. It can be as simple as asking, what's the best way to communicate with each other? When to best reach out, and using what method? Face-to-face, phone call, video meeting, page, email, etc. Just a caveat that face-to-face or video or phone calls still have an important role, as much can get lost over email. So depending on the nature of the feedback of the plan, an actual conversation as opposed to a quick email would be warranted. And also when remote work is a factor, communication needs to be more intentional and proactive. I think many of us have felt that over the last several years. It's not as easy as stopping by someone's office or turning to the person in the nearby desk sometimes. So a communication plan becomes even more important in these instances. So if a constructive, respectful, regular, and timely communication approach is used, that opens up the ability for candid discussions on how best to improve plan quality. Finally, we have continuous learning and education. Education is an important factor for plan quality. I think we all know that because we're all here today. But in addition to that, it's not only the amount of information we have in our heads, but also a mindset for continuous learning. Continuous learning has a few elements. The first is a willingness to learn. We can view the process of improving plan quality as an educational opportunity. They can be for the planner as we provide feedback during the physics or physician plan review, but also vice versa. So when giving feedback about a plan, include the reason and the context for that feedback. Don't just say, please change this and walk away, but rather explain the rationale and why the change is needed or beneficial. This is especially important for plan quality, I think, because as you recall, there is that spectrum of quality and it can be very subjective in nature. The additional context for the planner as a learning opportunity also allows for more understanding and therefore helps to make it stick, really making it more likely for the planner to remember in the future as well. It's helpful if we're able to give specific suggestions for improvement of the plan as well. And this really underlines the importance of physicists having that baseline knowledge of treatment planning techniques, and then also constantly growing our knowledge for how to improve plan quality. Also, hence the importance for this course as well. So here's another example that I do. I use plan reviews to learn more about different ways to get a good plan, especially in challenging cases or unique patient situations. Often, if there's nothing wrong, there's no error I caught, or nothing actually needs improvement, I'll still ask the planner about it solely for my own education. I'll even start the conversation with, I've got an education question for Leah, and then we go from there. Many of the planners know that starting question very, very commonly, very well. So in the context of continuous learning, it's important that new knowledge for improving plan quality should be shared with all staff. So not just for me, just for Leah, but also if there's something that's important to know in terms of changes to techniques, it should be shared with everyone. And I think this is especially true in a field that's as complex and quickly evolving as ours. So some ways to share some of these one-on-one educational moments to the rest of the staff could be if you could provide a forum to more easily share that knowledge. Some examples could be using incident learning systems or internally track feedback from different physics plan reviews and then share that with the team in a constructive way. Create a forum for training in services to communicate teachable moments that can highlight tips or pitfalls in the planning technique with these actual real-world examples. And finally, I think it's important to not forget to celebrate and learn from successes. For example, use great plans as educational case studies. Highlight and share the techniques used to get to that great plan quality so that others can do the same in the future. All right. So should I pause right here? Do we have some
let's pause
questions?
for a few questions.
Great. Excellent.
So first, there was an excellent comment in the chat that I will just read out for everyone because it is so important when creating this team-based approach. And someone said, when we understand that all the members of the team are important and equally responsible for the good outcome of our patient, it becomes easier to communicate and to collaborate for the same objective. And I just think that's really heartwarming and just exactly what we're hoping to portray with these slides. So thank you for that comment. And so, but we have an expert here, Leah, for this next question. So I'm pretty excited about it. How do you report incidents and install a reporting culture?
Right. Yeah, that's a fantastic question. It is very difficult, right? I think we know there are some barriers to reporting incidents, right? We're talking about bad things, right? Negative things oftentimes, right? Like, oh no, we made a mistake or whatnot, and it's never comfortable. And so turning those into learning and areas of improvement really makes a big difference. So there's a lot of techniques to that. But I think first, the biggest thing, what we did was actually we learned from others. So I went to lots of different sessions, talked to a lot of folks who had done this in real life, but really distilling it down to setting that goal, like we're going to do this, and identifying what are the barriers first to overcome it, right? And so barriers to starting an incident learning is that kind of fear of punitive response, like, oh, it's going to be all negative, nothing good's going to come from it. And then asking people to do more to report, right? So kind of more work and not good results coming from it. So overcoming those barriers starts with kind of sharing that, communicating and sharing that goal. Like, no, actually, we're going to learn from this. We're going to use these to improve our workflows, improve our patient safety, and actually make good changes. So making sure that it's useful for good things and then making incident learning an easy thing to do. So there are lots of tips and tricks for that, but really focusing on overcoming those hurdles that's really the most important first step. Did I
Great.
answer that question? I hope. That's like a whole lecture, I think, though. So it's a great question.
Oh, I think that was excellent. There was a question that I'm going to answer. So there was a question on if we have checklists and can we share them? And so one thing that our team has spent a lot of effort, we put a lot of effort into creating checklists for this course, and those checklists will be shared with everyone. And we have checklists for just a general plan that if you're reviewing any treatment plan you can use. And then we have 10 to 15 site-specific checklists that have details that are pertinent to each site. So we're hoping that those checklists will improve the safety of your plan review, the ease of your plan review, and you can take them and adapt them really in any way you see applicable to your clinic. So we will be able to share that. And there are a few more questions in the chat. I think let's save a few of them for the end and we'll keep going, and then we will come back to those at the end.
Okay, great. Okay, so I've laid out some tips about 3 elements of culture, but you might be asking yourself, okay, this sounds great, but do we really have time for this? This seems like a lot. I'm not sure if this can actually happen in real life. So yes, changing culture, moving from adequate plans to high plan quality is going to be hard, and many of these tips can be difficult to achieve in practice. And really recognizing that we do face resource constraints in reality. So how do we address those constraints to still be able to establish a culture of plan quality? So an obvious time constraint is time pressure, the time needed to create and review a high quality plan versus the time the patient is waiting to start treatment. So we all kind of understand this. I know if I was the patient, I would want to get treated yesterday. So this is where planning time guidelines come in and can be very important. Creating and sticking to as much as possible. I know it's difficult, but with the aim of striking that balance between the time needed for high quality plans and what's actually achievable. So having that timeline laid out. Furthermore, we recognize that it takes additional time and effort sometimes to generate a high quality plan. Although ideally, if we can come up with tools and techniques to actually decrease that time, which I'm sure you'll learn later in this course, that would be the goal, right? But, recognizing that at least at first, there's going to be these barriers. So, and then these challenges as well. And knowing that these challenges can increase if there's an imbalance between workload and staffing, right? Too much work, not enough staff, right? It's difficult to do things differently when you're just trying to keep up with your day-to-day tasks. But if you consider that, thinking about if when you're doing a plan review and you have to change the plan later in the process or right before the patient starts, efforts needed to make those changes actually increase because you have to go back to the start and redo so much more. So it's ideal to catch issues and try to improve plan quality, not the day before treatment starts when everything is complete, but as soon as possible in the workflow. So that's one technique to try to consider. Some institutions have implemented plan pre-checks, where portions of the plan are checked earlier in the process. Peer review could also happen not only at the end of the process, but earlier on to check the intended dose levels or contours. Excuse me. In our department, we have different series of peer review that we had moved from just looking at the plan at the end, but actually as soon as the plan is, the patient has been simulated, or some small group review with the physicians of contours. Now, automated tools can be very helpful for facilitating earlier checks, and I know we're going to have a whole session about this as well, about automation. But just thinking it through in terms of resource constraints, if a planner can run a program that checks some items that's able to be checked well by automated tool by just clicking a button, that would be incredibly beneficial by allowing the planner to catch different things earlier in the process and make those corrections earlier at a smaller cost by using those automated tools. Prioritization is another way to tackle the challenge of resource constraints. First, consider carefully whether changes to the plan are worthwhile. For example, there's a difference between asking for a replan if the planner forgot to model the treatment couch, for example. If you had a plan with beams that enter through the couch versus plans where beams don't enter the couch, adding the couch to that particular plan, is that worthwhile or not? Especially for the ones that the beams don't actually enter the couch. So kind of thinking that through. Another way to prioritize is to start improving plan quality with just a subset of plans to focus on at first. So maybe starting with SRS and SBRT or other high risk or highly complicated sites. Finally, knowing when to read the room in the face of resource constraints, I think, is very important. This is when we want to use our soft skills very well, our communication approaches very well. So understanding when the system is strained or if a planner is under a lot of pressure is very helpful. These are situations when communication style and constructive approaches become even more important. So ultimately, we can't ignore the resource constraints that we face, but it's important to recognize that any quality improvement effort really is like swimming upstream. While it's difficult to achieve in practice sometimes, the goal is really to put in the time and effort now to more easily get to a better quality product in the end. And with that, that brings us to our next Zoom poll. So we've talked about changing culture and various elements of that culture. Which of the following do you see as the greatest challenge to assessing and improving plan quality in your clinic? And we'll open the poll. All right, we'll have maybe about 1 or 2 seconds. We'll close the poll. That's great. We're about at 60% participating.
Excellent. Let me end the poll.
All right.
Share results. Very interesting. Knowledge and education is the biggest category.
Yeah, very interesting. And that's fantastic because I'm very excited for the rest of this course because hopefully we can address that here as we move forward. That's awesome. Yes, very interesting. Great. Well, thank you all for your participation. Before I turn it back to Lindsey, any other questions?
We do have a few other questions, and I think it's a good time for them. So the first question is, I have a question related to treatment plan reviewing, and this participant is wondering if in your practice, is it left up to the corresponding physician alone, or does it require peer review as well? So is it a collaborative process when we're reviewing treatment plans, or is it just the physician reviewing the treatment plans?
Sure. Yeah. In our practice, we have the physician reviews the treatment plans, then approves the plan, and then physics does their physics plan review after that. But once the plan has been reviewed by the physician, it also gets reviewed in our chart rounds or peer review by other physicians. So we have peer review for the physicians every day of the week so that they can get, we can make it through all of the plans and then patient simulations as well. So it's a combination of both, but the attending physician is the one who approves the plan, but then it does get presented in peer review with the other physicians and planners present.
Yeah, and I think that's really important. So we do the same thing in our clinic, although there was also a question about sharing practical tips to make the workflow more homogeneous for plan reviewing for day-to-day use. And I think that one thing that we do in our clinic that helps a lot is that if one of our planners, and physics plans sometimes, some SBRT and SRS plans as well. So we have both dosimetrists planning our patients and physicists. And particularly, we have a really good relationship with our dosimetry staff, such that we work together really commonly prior to the physician review of the plan. So if a plan we know is going to be particularly challenging, or the dosimetrist has some questions, they will come to us early in the planning process, and we'll work together to see if we can come up with a really good plan prior to showing it to the physicians so that they don't have to review the plan and they've approved the plan. And then it comes to physics and we find something that can be improved. And then it has to go back to the planning stage and you have that cost that Leah was talking about. So that's one practical tip that I can provide to make that workflow a little bit more seamless and homogeneous. And there were some other comments about physics staffing and what are the numbers. That's a tough one. I think everyone is always advocating for more staff, and that is so important. I know it's a really big global challenge. There's some references that we can provide that might be helpful that give some safe staffing levels. It's called the Safety is No Accident Report, and it talks about number of patients treated, your HDR load, how many linear accelerators you have, which can be really helpful in advocating for staff. But you're so important, or you're so correct that staff is really so important. Leah, do you have anything you wanted to add about physics staffing?
No, I agree. That's such a tough one. I think some things that can help, right, is I think even with Lindsey's example, right, where they implemented kind of standardized templates, standardized planning processes. I think the moving towards standardization in certain things, you can't standardize everything as we know, but that can help make the process more efficient as well. So understanding that, okay, yes, maybe we don't have as much control over the amount of staff we have, but identifying where we can, make ways that are more efficient, make things that are more clear. And then kind of the example that Lindsey had said about trying to reduce too much extra cost of having to redo things and moving things up in that process helps to, I think, what things that we can do with that. But I agree, staffing is always a tough one, identifying kind of where kind of looking at the different workflows, I think, is the first place to start, and identifying where we can make things more efficient with that, given that constraint.
There are a few other questions. I think we just have a few slides left on kind of the course outline, and then we'll open it up to a question and answer session. So I think we can save these last questions for the end, and I will share my screen again, hopefully the correct one this time. Yeah. Okay, can everyone see my slides?
Yep.
Great. Okay. Well, we're going to just finish with the review of the course outline. I keep clicking and then not advancing my slides. There we go. So we hope to really have some exciting content and skill building coming your way to reinforce some of these concepts that we've been showing and to really highlight the tools and skills that you need for creating these high quality plans. So on the right-hand side of the screen, you see the schedule that Emily also shared at the beginning of the session. This is the outline of the next 12 or 13 sessions. And by the end of this course, we're really hoping that you've learned how to effectively evaluate treatment plan quality. Like I said, we're really hoping you'll have viewed many clinical examples that will allow you to identify areas of improvement when you're reviewing plans. And we're hoping that you'll be feeling on the path to enlightenment and just have the tools that you need to continuously learn in this space. It's not a space that people talk a lot about. There was a question in the chat about a resource for reviewing treatment plan quality. And to be honest, I don't know of a good one. It's just something that because of the subjective nature of the review of plan quality, it's something that's often taught in resident education, person to person, on the job training. It's difficult to synthesize this kind of clinical experience into a reference. And that's why we really felt that this course would be so important to all physicists and really all clinicians, because we have this intuition that we gain from on-the-job training, but it's so heavily dependent on the people who train us and the experience they have and the experience, like our experience over time that's gained just through seeing these cases that can be improved and or just happening upon them. And so we were really hoping to create a repository of all of the information that we have, both with the checklists and the presentations, as well as a clinical database of examples that we'll be sharing with you, similar to what you used during the pre-course prono survey, but we'll have even more examples to share with you that you can go through at the end of this course. So, and just leaving you with some final thoughts after today. You really have the ability to make a big difference on making treatment plans better for patients in your clinic. In order to do this, it's imperative that we learn the skills of treatment planning ourselves. Because I always say, you know, you can review a plan, but if you don't know how to create that plan, it's very, very difficult to have the intuition you need, or it takes a longer amount of time to gain that intuition. So this is where I'll put a plug in for tomorrow's session. My colleagues Adam and Brendan will be providing a refresher if you have already attended some of the RCC treatment planning courses. It's maybe a refresher on how to create the best quality VMAT treatment plans. But we've actually, as a team, been working to improve the method, and we've made some changes. And the slides that they have tomorrow to show are really excellent. So I would really encourage you, even if you have attended past courses, to attend tomorrow's session. I think you'll have a lot of benefit from it. And just a reminder, as Leah was saying, when we're reviewing plans, always thinking to yourself, reviewing with a critical eye. I'm always thinking to myself when I'm reviewing plans, would I want my mom or my grandma to be treated with this plan? Thinking to yourself, are there any ways within the scope of my knowledge that I think that the quality, the safety, the robustness, or the efficiency of this plan can be improved? And finally, working towards a culture of quality with your team, promoting just that culture that Leah was talking about, being very collaborative, communicating effectively, and continuously learning and improving together. So there may be a lot of potential hurdles to promoting that high quality treatment plan. Creating that culture is not simple, but Leah really did provide so many strategies that can help mitigate these challenges. And so I would suggest that you just try to bring some of these ideas back to your clinic, see if they would help improve the environment, the communication. Education is so important. Really having that mindset of being a continuous learner. I'm always telling my daughters this, like it's not, you know, we are not stagnant as people in life, right? We are continually learning and learning from other people, learning from experiences. And as long as we have an open mind to that continuous learning, we're going to be that much better of a clinician and provide that much higher quality care for our patients. And just reminding yourself that things won't always be perfect. You know, there's going to be mistakes that happen, but learning from those mistakes and really trying to work together as a team, I guarantee you'll see some really excellent results when these strategies are implemented. So that brings us to our last Zoom poll. And we're just gauging people's thoughts on, at the start of this course, are you feeling excited? This is what you were hoping for. Are you hopeful that the course will positively impact your patients? Do you feel nervous that you won't understand the content? If so, please do let us know, because that will help us kind of tailor how we deliver the course. And then hopefully this wasn't what you were expecting, but you know, there's always that chance. We have about 60% have answered. And it looks like it's pretty evenly split between the first two. So that makes me very excited. This is a huge passion of mine, and I really do hope that the next 13 weeks will be helpful for everyone. I know that I have learned so much from people throughout my career, my colleagues, my physician colleagues, my planning colleagues, therapists who teach us how to, really feedback from therapists is also so key. We think we can create the best plan in the treatment planning phase, and then it gets to the machine and to our patients, and really didn't work out in practice as we were hoping it would be. It wasn't practical. So really just learn so much from everyone. And we hope that we can share that expertise with you.